emotional when we talk cancer, right? It's always very emotional. Dr. Ajay is here. Dr. Ajay, good morning to you.
Good morning, everyone. Good morning, Lagos. It's good to be here.
It's good to have you here. Yeah, colorectal cancer. Dr. Ajay, how do we dig in now? Where do we start from? I've tried to bring some perspectives to this conversation. Colon cancer. It used to sound quite uncommon in Nigeria, but what I read earlier, it's almost like it's very common, very, very common.
Yes, it's very common. It's quite common, and that's why the public health importance of it is what we should all pay attention to. It's one of the diseases that has a good screening, such that if you identify it at early stages, stage 1 and 2, chance of survival is as high as 90%.
Oh, nice.
So if it's identified late too, the chance of survival drops to as low as 15%. Then it's a disease that of course affects both genders, and it's a disease that statistics shows that the onset amongst Nigerians, Black Africans, seems to be earlier than what we have in the West.
Oh. Is there any genetic reason for it?
Yes, there's a genetic reason for it, and maybe just because of the kind of lifestyle that we're beginning to adopt, the westernization and the globalization as it affects activities and diet, that making us predisposed to these diseases, and it's coming early.
What are the early warning signs?
Okay, so they are the asymptomatic group, right? Those who just go for the regular medical checks and they discover that there's a rise in the number. CEA is the carcinomic is an antigen, carcinoma and embryonic antigen, that is used to test for the presence, though not as specific, for colorectal, but the elevation in those numbers, tells us that there's something going on. So if for any reason he goes for a colonoscopy or goes for that test and the numbers are elevated, then should be investigated. But other conventional warning signs is when you have stool, you have blood in stool, all right, and you have an alternating episode of diarrhea with constipation, and this is the story. So when there's a swelling in that tube, the swelling blocks the outflow of feces for some days, pressure builds up and it releases it. So there's constipation, then there's diarrhea. There's constipation and diarrhea. Then unplanned weight loss. Right, person is losing weight without having to be on any diet is a warning sign.
What necessary stage could that be?
Okay, so
can that be attributed to any of the stages that you mentioned earlier? So
when there is an alternating diarrhea with constipation, it could be in any of the stages, stage 1 to 3. So
Doc, please hold on. I am very, very sorry. We need to head out now. We need to take this break. Okay. We'll continue with the early warning signs in a moment. Lagos will be right back.
More talk, news, and sports after this.
Morning.
Welcome back to Health Thursday here on Nigeria Info 99.3. I am so glad that we have a community of like-minded people who are here on this show today to get informed, to get educated, to know more about their health. Dr. Ajay Adepiton is here. He's a consultant oncologist with Luth Cancer Center. Dr. Ajay, thank you again. I know, I've been to your office. I know how busy you are, but you still give us your time once in a while when we call on you. Thank you so much.
Grateful.
Thank you. So let's get back to the early warning signs. Okay, the constipation, diarrhea.
So we talked about alternating constipation and diarrhea. We talked about the bleeding when someone goes to the toilet. All right, he bleeds with the stool. Now that could happen if there is some hemorrhoid or the stool is hard. But when you've had it back to back, right?
How often is back to back?
All right, so an episode lasts for like 2-3 days, then it wanes off. Then another episode comes within 3 to 4 weeks, and it wanes off. Within 6 months, you're having that repeated bleeding. It's a red flag that you should know. Then, I mean, these are the emergency signs. The emergency signs is abdominal swelling, and there is a protracted abdominal pain. Now, because of that obstruction that's happened in the gut, right? So a part of the gut may begin to swell because feces wants to pass through, right? And because the obstruction, then some dry hard feces at that obstruction site, then the parts distal to, or the parts before the obstruction now begins to swell. You know, like a traffic when there's a jam, right? So the part begins to swell, and with that swelling comes abdominal pain. Now, that's a very dangerous symptom to have. If the person doesn't have an emergency relief through an emergency medical surgery, that gut could rupture. And if it ruptures, now you now have fecal material spilling everywhere into the abdomen, and it's a dire emergency. So that's emergency symptoms. So other symptoms could be, I mean, when they say that, okay, the person is losing weight and he's white, he's pale, loss of appetite, nausea and vomiting, and then yellowness of the eyes, or of deep yellowness of the urine. And those are other symptoms that could come with colorectal cancer. Now, the deep yellowness of the eyes, of the urine, or the weight loss are late signs, very late signs.
They are late signs.
They are late signs.
Oh, wow. Okay. I mean, I wanted to add something to the early warning signs, which is the ones that people ignore. Are there any early warning signs that people often ignore?
Is the stool? Is the blood in stool?
Part?
Is the blood in stool? And you know, we just call it jedi. Right, in the local parlance, and most people will just visit the alagbo and they will mix the agbo for the person and say, you know, and that is usually the warning sign that a lot of people miss.
Let's talk about late presentation. How bad is it?
The late presentation gives an overall survival of about averagely of 40 to 50% survival. So at stage 3 you have about 60% survival, and at stage 4 have about 15% survival. So late presentation is not good. Everybody should go for a screening. If you are approaching 45, then you should go to screen, so that we don't avoid stories, stories that break the heart, and don't suddenly realize that you have a stage 3 disease or a stage 4 disease, which treatment is not going to cure.
How often should people screen?
Okay, so if we're talking about screening, there is the gold standard of screening, that is the colonoscopy. The colonoscopy is like a tube that has a sensor in it, that has a camera that's attached to a flat screen TV. It's passed through the rectum, and as the tube progresses, in fact, the person can see the inside of his colon on the monitor, and there could be growth, small growth, or inflammation, and anything. So what the surgeon does, that whenever he sees any suspicious growth, the tube has with it small like scissors that can use in taking a bite of those growth. And when there's an ulcer or anything suspicious that should not be in that environment, so they could take small cuts and small bites and take it to the lab. So a man who is so let's take it this way. So there is the average risk individuals, and there is the higher risk individuals. The average risk individuals is someone who is you are 45 years old. Okay. Average risk individual. So you should do that screening, and you should start doing your colonoscopy at the age of 45.
45.
Right. Now, if you're a high risk individual, you should do your screening at age of 40. Now, what defines high risk individuals are people who have they have a relative, right, who's been diagnosed, or they have a second level relative who's been diagnosed, or someone who's had a similar disease in the past, all right, or someone who's had inflammatory bowel disorders. These are people who have high risk. So screening for those high risk individuals can start 10 years before the member of a family,
like 30, 35,
30, 35, right? Or averagely at 40, they could start the screening. So colonoscopy is gold standard. However, there are other investigations that could be done. There is the fecal occult blood test. Right, the fecal occult blood test. I mean, you walk into an average standard lab, they could do that for you. Get fecal sample, put it in the kit, and test for microscopic evidence of bleeding, because that's where it starts from. Then there's the fecal immunochemical testing, the FIT test. These are other tests that could be done. Then there's a sigmoid colonoscopy or sigmoid a CT colonoscopy that can be done through an imaging. Will look at it. Now, the interesting thing is that either the FOBT, the fecal occult blood test, or the FIT test, when those are positive, you will need to do a colonoscopy. The colonoscopy is gold standard, and screening starts at age 45 for most people, and age 40, or at the age on which a relative had the diagnosis, then you should start screening. And the beauty about screening is the fact that those who get screened are usually the ones who will benefit and have a higher chance of survival and treatment. I've met patients who have had treatment 20 years, 15 years, right? And they're doing well and they're doing fine. Now, the privilege they've had is the fact that they caught the disease very early. And they're doing well with it. So screening saves lives, and it's even cheaper, right? And you have a better chance of cure when you're able to screen and you catch the disease early.
Doc, I hear you. You've talked about ages, but let's talk young people's exposure. Do we have young people in terms of colorectal cancer now?
Okay. So
what's the population of young people?
So there's a study that was done, adolescents and young adults, colorectal cancer, and is there, right? It's there. The young people, have been privileged to manage some young people, 18, 21, 23, 26, in the tertiary institution, and the numbers are there. They are rising, okay? And they usually have a rather aggressive disease, the signet type of adenocarcinoma with a mucinous secretion, and which makes treatment challenging. So the screening doesn't end with those who are in their earlys, all right, who are in their early 40s or 45. If there is a family history. Now, it is also important for me to mention that this group of young people usually may have a syndrome that is called Lynch syndrome. Okay. Right? So when they have that Lynch syndrome, they tend to present earlier in life, right, in the early 20s, and their treatment is usually very daunting.
Oh,
yeah.
How why?
Because the disease. Okay, so there is a factor of the tumor biology, whether in America, in Europe, or in Africa. A tumor biology that is poor everywhere. Now, the cell type, which most common in this group of higher group, is the signet cell type. Signet ring cell type. Now, the signet ring cell type is a bad prognosis cell type. So it makes treatment difficult. Then we talked about tumor biology, we talked about cell type. Then if there is any syndromic relationship with the disease, it also makes it difficult. That is another point where screening comes in.
What does that mean, syndromic relationship?
Okay, so with this group of people, they've been associated with having Lynch syndrome.
Okay.
All right.
Okay.
So they have, when you look into their guts, they have these tendencies of having adenomatous polyps. Now, polyps are outgrowth. They are outgrowth from the intestine. In the inner wall of the intestine, they just have a tendency of growing out. Now, that is the pre-invasive lesion of colorectal cancer. So these people with Lynch syndrome have this tendency of having this many growth coming out from the wall of their intestine, which could transform into the colon cancer itself.
Look, I want to talk about something pretty connected to, well, I think should be connected to colorectal cancer, which is food. What's the connection between food and colorectal cancer? Are there foods that predisposes somebody to it, are there food that someone can take to reduce the risks of coming down with colorectal cancer?
Okay, so diet